For the trochanteric fractures, can we do a two-stage instead of one stage, and does it have any advantage?
I didn't understand your question.
So like you're removing the implant in one stage and
Oh, no. If you are suspecting infection, then yes, two-stage. On the table, that's the reason you have to be extremely careful. You expose the implant, see whether there is any granulation you suspect, and if you have a fantastic lab, you can do a gram stent, but that is not reliable. If you have little doubt, do a two-stage. You are better off. Otherwise, single stage.
Yeah, Dr. Pachore, excellent work and excellent guidance for younger surgeons. You mentioned this has to be treated like a revision situation. Any experience with distal locking, or do you believe that this is distal loading should be repeatedly used in all this? That is for one. And second, your trochanteric fixation with additional plate. Is it okay if someone uses only wires instead of the hardware that we create? So,
Yes, you go ahead.
yeah, so my first question is, do you use distal loading or distal locking, and what is your experience on with?
We did in past, but that is no more available, and probably you do not need that. After probably with a Wagner stem and modular stem, it is, I think, adequate. But if the canal is more than 18 millimeter or so, it's a very wide canal. Yes, it is one of the good choice of distal fixation. Probably just to name, Rift today is available, but Escalab has stopped in India. So once in a while, we used to use the distal loading in a very, very wide canal. Then you have a choice in this. If the patient is elderly, do a cemented here. But be careful of cementing for this elderly group of patients. And second is your trochanter. You do whatever the way you want to do a stabilization, but trochanter must come back. It is usually sometimes is a fibrous union, but it doesn't get migrated, so it will reduce the chance of your dislocation.
With wiring, I think the trochanteric tenderness doesn't disappear, the lurch of the patient doesn't disappear. So what is your take on that?
Sorry?
Patient's lurch doesn't disappear.
They are going to have a mild lurch, but that is okay. They are not going to be absolutely normal because it's a very extensive surgery. Whole biomechanics have changed. So they will have mild lurch or limp, whatever it is. And majority of these patients are going to use the stick. They are very elderly, 70, 80, 85.
Okay. All right, next. What are you pointing at? Question for Dr. Pachore. What's that?
Question to Dr. Pachore.
Okay, let him go first, Dr. Murthy. Yes.
So the K-wires that you have shown for the fixation, like what is the incidence of K-wires breaking up? Like I have seen few x-rays in my practice where the wires have broken. And what are the tips that you will like to give us that these wires don't break? And last part, what is the weight bearing protocol? When you have fixed a trochanter like this, what is your weight bearing protocol after this?
Just to answer the second part, weight bearing straight, next day morning. You can't make them in the bed because they're very elderly, you will land in complication. Number two, wire, don't use a very thin wire, it will be about 1.5 or 2.2 millimeter. And you must try and get an opposite cortex done, opposite cortex. If it is single cortex, they will just migrate out. Chances of non-linear are about 5 to 7%. But trochanter doesn't migrate, it has a fibrous union, and most importantly, you have to keep the vastus lateralis and trochanter sleeve intact. So they doesn't migrate. There's a second important point. Allow not to touch the vastus lateralis too much.
The wires will always break.
Yes.
Yeah, because I have seen so many wires flying around, I have started using Ethibond number 5. And don't show flying around, and it gives a good fixation otherwise.
I told you, we have a publication you can go through.
But the wires break often, and it's a common problem. All right, microphone 1.
So you mentioned about cemented stems, but there is usual apprehension about cementing into a previously instrumented sclerotic canal. So what is your?
Yes. If you are doing for a very acute patients, there is a chances of what is called bone implant syndrome, cement syndrome. So we have to be slightly careful. But those who have already intramedullary nail or something, the chances of embolism are less possible. And what I told you, the cementing, better cementing, the screw holes, bigger screw holes, you will have to block them. What we do, if there is a DHS or 4 screws are there, we use the unicortical screw and do a cementing. You must do a cementing in a younger soil, in a non-morbid patient, you can do what is called third generation technique. But if in an elderly population, don't do too much of pressurization, keep your central CVP at the almost about 12 or 13 and see the hydration is there, good hydration, so that you don't have chances of getting that syndrome.
Yeah, I would say in these cases, generally speaking, cemented stems are more challenging with all the screw holes and everything else. So I would stick with non-cemented fixation. All right, microphone 4.
Yeah, the indications and decision making for doing a dual mobility hip in these cases is one, and second would be, these new GTR plates with cables, your experience with that, because I feel like that gives a very strong fixation for the trochanters also.
Yeah, cables I have not used, but cables are used for transfemoral, not for this. And these are very cheap, just 2 KYS and the tension band, AO tension band. That is the reason we have been using that. And number 2, double mobility. If your system is not allowing you to go to 32, 36, probably double mobility is the choice. The cups which are less than 40, 44, 46, I think better to use a dual mobility in this group of patients. And fortunately is available in the country.
Thank you, sir.
There are a variety now of very good trochanteric cable plates that have options for multiple screws, unicortical screws, and so there's better materials out there. All right, microphone 1.
Sir, you had shown one case with the trochanteric plate, and then you had shown the wire technique that you have shown. So what is your experience? Is the wire technique superior than the trochanteric plate, because the plate can be, it can cause trochanteric bursitis later to the patients. So what your experience, which is superior, the cable technique or the trochanteric plate?
No, trochanteric plate, the fragment is large, reverse obliques. The trochanter, when you have a subtrochanteric extension, better to put a plate, If you are going to keep the proximal fragment intact and trying to reduce that, better to put a plate, because that's known as a composite fixation. And whatever the head is available, you put a medial side graft, which will heal up early.
Thank you, sir.
All right, microphone 2. Good.
2 questions. Do you use C-arm on the table or not?
Most of the time, no.
Yeah. No. I always use it.
I agree with you. You can, but when a lateral position, it becomes slightly difficult to get the C-arm inside.
Okay. Second thing is how to prevent these IT fractures from such a high complication rate. Failure of PFN, failure of DHS in geriatric patients, and I have an innovative technique.
I know, which I want to pass this message to the crowd. Because of lack of time, I could not put this couple of slides it is a composite fixation which has been devised. Unfortunately, we should come with a free paper, good paper, randomized trial, what always CS Ranawat tells us. So that paper, you must bring it out, because it's a composite fixation, intra and extramedullary. Definitely, I do agree that fixation is absolutely. I agree with you.
Thank you. Microphone number 4.
So failed DHS versus failed PFN. The recent study shows higher incidence of instability in failed PFN cases.
Yeah.
Mainly because the gluteus medius is affected. So does that affect your plan?
Yes, absolutely. That's the reason I told you. The extramedullary implant have very low rate of complications. You can treat just like a primary. But those with intramedullary, we have a lot, because the proximal bone is absolutely, it is eaten up by your nails. And that's why, and the canal, the neocortices, which does not allow the broaching. So your implant does not become stable. That is another important thing in that case. And most of the time, trochanter is shattered by your big nail of 17 or 19 millimeter.
So the level of constraint, do you upscale your constraint?
Absolutely.
Microphone 2.
Right. Excellent academic deliberation. My question is to all our esteemed panelists regarding the first case of protrusio. Do you guys see any merit in application of 3D printing technology in one, planning, like getting a model for that difficult case of protrusio, and second, any merit in 3D printed implant, like 3D printed cup?
Anybody want to take it? Go ahead.
Yeah, 3D printing, if you don't understand the anatomy and the shape of the deformed anatomy, just getting a 3D print of the bones might help you to understand where it is. Some people make 3D printed cutting guides to get your neck osteotomy. If you didn't know where to do the neck osteotomy, it might be helpful. And if you've got, if you think you're going to have problems with your acetabular component stability, if there's not enough peripheral bone to support it, then you may want to get a custom triflange, they call them in North America, or a 3D printed acetabular component. That might be helpful too.
3D printing has a role where you have a aseptic losing and huge bone loss, pelvic discontinue kind of thing. On such kind of cases, the huge literature is written about, everything is talked about it, and there are guidelines, so I don't think so 3D printing is needed for this particular case.
Any use of 3D printed implants? Cup.
We can manage all these
Patient-specific
ankylosed patients with standard implant which is available, and we don't really need to have 3D printed unless there is a loss of bone or acetabulum is deformed because of some injury, trauma or fracture.
Case discussed, the protrusion today was more like a fracture case rather than a pure orthopelvis. So in a pure protrusion, I think it's an overkill to have this 3D printed implant, 3D printed planning, etc. But if we are dealing with a case like what you have done today, if you have a lot of bone loss posteriorly, posterior column, or including the more severe bone loss posterior column or whatever, I think we may need a 3D printing. Yeah.
Thank you.
Microphone 4.
Hello sir, my question is sometimes the trochanteric fragment are highly comminuted, and because of the osteoporosis we can't reconstruct that as much as we want to do. So how you assess your version of the femoral stem while putting in the posterior approach? Because we have only hollow medullary canal is there.
Your tibial axis is important. If your tibia is at 90 degrees, you will know that how much anteversion. Mostly all these patients, instead of 5 degrees, we might increase to about 10 to 15 degrees of anteversion in this group of patients because of the high risk of dislocation. So tibia axis is the right thing for posterior approach. And if you comminuted trochanter, it is better to have, instead of just 2 KY, you can put a multiple KY and put a tension band on that, because trochanter sometimes is not in one piece, sometimes it is a vertical split, which has been, we have already described this.
Thank you, sir.
Can I just...
like 2 parts to the question. The first part is how many in the panel would do a simultaneous bilateral, and what are the precautions or build-up measures that they take, because my experience has not been very good. Like I have done around 10-15 bilaterals. After that I just gave up because they used to have such high chances of tachycardia. The heart rate would shoot up to 160, 180. We tried everything. We tried giving blood immediate post-op. We tried transfusing blood intra-op. Even if one sponge is only spoiled in the surgery, we tried giving them heparins. Everything failed. I talked to a few of the anesthetists around big centers, and I asked them that, how are you managing? And their answer was, boss just does the job and leaves, and we are messed up for the whole night managing all these issues, the tachycardia and everything.
So for the take-home message, we should not get carried away with this simultaneous bilaterals in these kind of complex primary cases. In fact, it is safer to do a staged procedure rather than trying. It's all depends upon the teamwork and how good your anesthesia team and your whole theatre setup and everything. So best the message will be better to go safe staged procedure. But if your team is good and then you are skilled enough to do bilateral.
My question is not what is better. My question is how many of them are doing simultaneous, and if they can give us any tip, like what extra can be done to prevent these tachycardias.
So bilateral simultaneous in a young patient, properly optimized, good hemoglobin, patient understand what you're doing it, and not too many complicated or complex cases. And your team knows it, you're working in an institution with your anesthetists who are trained to do the job, you have a protocol to do it, you should do it. You can do it.
Yeah, we do it routinely. You should be confident, and once you start doing, the steps are very fixed. You just cut the neck, debulk the bone, put the cup, and so that's little extended than routine. So once you start doing routinely, I think you will get up, because there are benefits. You can move the patient safely and...
Sir, I beg your pardon. My question is not what surgeon can do. I can do a hip in like 45-50 minutes.
Part is case to case.
But it has been like terrible. I just used to see...
But you need to speak with your anesthesiologist and recognize they're part of the team, and bring them in and on board, because that's what it sounds like the problem is. They're falling behind on your patients right, from the hemodynamic point of view, and that's why your patients are getting into trouble.
It's, can I just add one more?
Sure.
One important thing.
Only one tip for you is, it's exactly the way you manage. If you have very complex revision which takes 4 hours, and you do the same thing, whatever you do for that patient, you do the same thing if you are doing the bilateral together. It's no different.
Like young
because
patients.
it's longer surgery, the blood loss is more. The way you manage the double, you manage the one which takes 4 hours.
Yeah. All right. It's an anesthetic problem. All right. Microphone 4.
So screw placement, acetabulum screw placement in unstable situation. So you have a dome screw and a column screw. If you are getting a good ischial column screw, do you still need a pubic rami screw to prevent the abduction failure of the cup?
The basic thing is you need to have one screw inferiorly, either pubic rami or to the ischium, not both.
What you are talking is important for complex revision where the bone contact is poor. So in those cases, you need this pubic and ischial screw.
Yeah. Dr. Mookie, okay, 2 more questions and we're done.
When do you do the femur first? In a severe osteoporotic bone, I do the femur first, so that in your retraction and reduction, your assistant, whosoever is the assistant, and I keep on turning the table and let anybody be the leg standing person.
Is this a question or is this a technique?
No, my comment I want. I want the comment. Yeah. Because I keep on turning the table maximum. I am not bothered about the assistant, leg holder or anybody.
Dr. Mookie, the benefit of doing femur first is we do not have too much option of version if you are using a monoblock implant in femur. So you put the femur the way you want and then you can dial the acetabulum version according to the femur. But that benefit is gone if you are using a modular implant or implant like a cone Wagner. You can turn the femur the way you want. So then it wouldn't matter whether you do femur first or acetabulum first. It's your convenience.
No, it breaks, no, because when you try to put pressure on the femur, sometimes it breaks. So it just collapses.
Even if you put the femoral stem up
then
the wrist, still it can break distally.
Last question.
Sir, what's your opinion on severe osteoporotic patient which have simple IT femur, whether we go directly with the long stem bipolar or we fix it? Because we see that most of the IT femur
simple fracture, fix it. Simple fracture, fix it.
We have published all this.
Yeah,
it is called primary prosthetic
failure rates are very high.
Yeah, primary prosthetic replacement for intertrochanteric fracture is done basically if there are 3 conditions met. Number 1, the patient is 80 plus. Number 2, the patient has very severe osteoporotic bones. And number 3, if there is a combination of trochanter. If these 3 things are there, then the chances of primary fixation failure is very high. It's almost 25 to 30%. So in those situations, you do primary prosthetic replacement, usually a cemented bipolar, and restore the trochanter as much as you can easily do. Restore the neck length, restore the offset with respect to the femur. And then the patient can technically stand the very next day and walk full weight bearing. But these are about 20% of the total IT fractures which you may see in your practice. 80% of them, they don't follow all the 3 together, and some kind of a internal fixation based on what your trauma experience you have is better.
Thank you.